Okay, let's continue with placental abruption. And we were talking about grade 0 to grade 3, from asymptomatic to severe tetany of the uterus. So you're thinking, oh man, look at this. So let me see. This does not necessarily, and I think students forget, this is not always a medical emergency. This is a medical emergency, of course. But sometimes moms have it and they don't even know they have it because maybe there's a small part, maybe the size of a 50-cent piece, what we call a retroplacental clot. It's a tiny bit of area in the placenta, in the middle, let's say, of the placenta that came off and it clots off. That is, that understandable. The mom is asymptomatic. And we noticed on ultrasound, it had no sequelae, it had no problems for her later. Whereas you go this way, it continues to get worse and worse and worse. And that means that the placenta is coming off in greater amount. From vaginal bleeding, mom and baby are not stressed, to now we have fetal distress because maybe part of the placenta is off. Mom is not exhibiting shock, but the baby's not getting his blood, and it's ending up in the uterus. So there's different degrees of what we call placental abruption. And if you look at it, we go through the criteria. Of course, there is eventual, if it happens, vaginal bleeding. You can have it present or not present, of course, depending on the grade, right? And then you'll have, in the worst case scenario, abdominal pain. It's an increasing tenderness. She can have so much blood in her uterus that she goes into shock. Hypovolemia, the blood's going into the uterus. She goes shock, meaning the blood pressure's going lower and lower, and she's what? She's not urinating because the blood is shunting to her major organs, which is not the kidneys. It's going to her heart and her lungs and her brain. She may have no urine. She goes into a coagulopathy, which is a DIC. So that's a problem right there. She's bleeding a lot. And the poor body's trying to what we call clot, but it uses all its clotting factors, remember, in preeclampsia. So that's the problem. Covillary uterus means that the blood collects between the placenta and the uterine wall. So the shock can be out of proportion to the blood loss because the blood is what we call sequestered inside between the uterine wall and the placenta. So she's not going to necessarily have a lot of vag bleeding all the time, as we notice here. The blood might be kind of sequestered or stuck in her uterus. She'll have blood in amniotic fluid, a positive APT test. Of course, she's losing the blood. Her H&H will be dropping. She might enter into DIC. And Kleihauer-Backe stain, meaning what? We can do that to see what happens in terms of the blood. It can go from the baby, the blood, to the uterus. And so it goes back into either in the uterus or back into maternal circulation. It's like a planned transplacental hemorrhage. So that is not good either. So this can be pretty serious if it progresses, correct? Ultrasound will reveal the separation. We want to rule out the previa. We want to rule out this concealed blood. Might be grade 0 or 1. We want to treat for hypovolemic shock, treat her for DIC. You're thinking of the possible problems. She has shock, worst case scenario, coagulation problems, and she's hemorrhaging. She can have a non-reassuring pattern, uterine hypoxia. And then we have expectant management and active management. When she's pregnant, if it's grade 1 or less, and the baby is less than 36 weeks with no distress, we'll just keep an eye on the baby. Remember, keep the bun in the oven, right, as long as possible, especially if he's in no distress. Do frequent serial EFMs, NSTs, right, the NSTs. And give her what? Corticosteroids. Now look at your OB medication protocols. And you're going to go, oh, I think I remember that. Remember the corticosteroid that we give the mom. Betamethasone. And it's in now this is the time in Unit 2 to review again your OB medication protocols. You're thinking, now what are these medications for? The betamethasone is given an IM injection to mom, usually 2 grams, first day and the next day. IM to what? Is it for the mom or the baby? It's for the baby. Increase what? Surfactant production in the baby. Just in case she what? Delivers less than 34 to 36 weeks, because we know then at that point in time, the LS ratio is not 2 to 1 yet. It only is 2 to 1 between 34 and 36 weeks. So if she's hemorrhaging now at 33 weeks, we'll give her beta shots. Active management, if she's in active labor and she's in grades 2 and 3, we'll give blood replacement, which is packed cells. We can give her clotting factors, fresh frozen plasma. We'll give her fluid replacement, LR, increase that blood pressure. We'll put a Foley in. And urine output has to be more than what? An ounce an hour. That's minimal for life compatibility. The kidney should be producing urine an ounce an hour, 3 mils per hour. So we want to make sure what? The blood is not shunting away from the kidney, because if it is, it's pretty bad. And the shock is getting worse. We're going to check a hematocrit. We're going to see if the baby if it's bigger and he's non-reassuring, there's a possibility we can vag the baby if she's hemodynamically stable. If the baby's dead, unfortunately, we can vag. We will C-section the mom if it's a grade 3 and it's a stat. Got to get the baby out and the baby's alive. So there's many, many different scenarios here. Make sure you understand the differences. So we can vag the mom as long as she's hemodynamically stable, and the baby's viable, or if the baby's dead. So let's look at nursing care similar to SABS and placenta previa. This is a hemorrhage case. This is a clotting case. And mom could be what? She could be a surgical case. Health teaching, vital signs, and obviously frequent NSTs. Cord insertion and placement, placental variations. So we will look at anything that could happen can happen. You're thinking, things that we learned in Unit 1, it's normal. And you think, what could happen in Unit 2? You go, the placenta can look different. And here we have it again, the velamentous insertion of the cord. And the velamentous insertion of the cord is the same as vasa previa when we look back in the notes before. And remember, we were saying that the cord vessels, 3-vessel cord, tethers out or branches out and then inserts into the placenta. And this is the main thing. Upon rupture of membrane or traction of the cord, they can pop off. They can tear off. And we're going to see immediate what? Fetal exsanguination and a huge change in fetal heart rate from suddenly tachycardia above 160, 180, 200, and sudden bradycardia down to 60 beats per minute, for instance. We have 2 other different ones we call Ballador insertion of the cord, and you're thinking, what? That's kind of a weird name. And the cord is inserted on the margin of the placenta. Now, same thing. You're thinking, if all these placental variations occur, is she really going to have a vag delivery? The answer is what? No. We cannot have her vag in the velamentous or vasa previa placenta. We can't have her vag delivery at Ballador because what? The cord might pop off. So that's not good, and it's a possibility for fetal hemorrhage. And the centriate placenta, where each lobe is distinct, has its own distinct circulation, and the vessels collect to the periphery. And you're going to see a picture of that. And of course, you're not going to definitely have her labor because those lobes can break off, tearing and postpartum hemorrhage. And then now we're getting to postpartum hemorrhage. Postpartum hemorrhage, I want to review with you, is a loss. An EBL or QBL, quantity blood loss, or estimated blood loss greater than what? 1,000 mils. Now remember we learned in postpartum Unit 1 notes, normal EBL or QBL for a vag delivery is what? Less than 500 mils. Normal C-section, EBL or QBL, is less than 1,000. So if it's greater than 1,000, either mode, it's going to be considered what? Independent of the mode of birth. It's a postpartum hemorrhage. So when students do the NCLEX questions, you've not got to do a lot of NCLEX questions. They'll say, okay, so, and it says here that she lost 1,200. I'm not sure if that's a vag delivery. It doesn't say, or C-section. So don't I need to know that? And you really don't need to know, correct? Because if it's greater than 1,000, it's postpartum hemorrhage anyway. So there's a lot of reasons, but I want to have you highlight the most common cause of postpartum hemorrhage is uterine atony, Remember we talked about uterine atony? It's a boggy uterus. It's not contracting. It's not involuting for many different reasons. And so we want to make sure what the main thing to do immediately is what? For a boggy uterus is to massage, massage, massage. And then do whatever you can after that, but we got to massage the fundus right away. And there's definitely different reasons why the uterus does not contract. And I want you don't have to memorize it, but just remember what can interrupt the uterus from contracting. Well, it's stretched out a lot. That would make sense. Anesthesia makes it slow down. Contraction. History of atony. Lots of babies, right? You know, it's my 14th pregnancy baby. Oh my goodness, the poor uterus is like worn out, right? Prolonged labors, trauma, forceps, multiple C-sections. I mean, the list goes on. Retained placental parts, right? Subinvolution, meaning involuting not, remember, 1 centimeter a day should be going down. It's going down like 1 centimeter in 2 or 3 days, remember? So that's not good. Hematomas, and of course we'll talk about inversion of the uterus. The uterus goes inside out. Well, it's definitely not going to involute. MAG makes it slow down. It slows down everything. Remember, smooth muscle. And ASA, remember, aspirin. That means bleeding. So you're infected, you have clotting disorders. So let's just highlight this. Uterine atony, the hypotonia of the uterus, excessive bleeding, and clotting. Our goal is always to increase uterine contractions and decrease blood loss. Massage, 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 massage. And then we're going to hang IV Pitocin. And I want you to look at the OB medication protocols. We can give her methogen PO. We can give her methogen IM. We can hang prostaglandins, which is not common in OB, but we can hang them. And we have what? Endogenous prostaglandins, which try to contract the uterus. Endogenous oxytocin from the pituitary to contract the uterus. We can give her hemabate or carbopros. It's in your OB medication protocols. And that is usually the last line of what we call uterotonics to give her, to get the uterus to immediately contract. Bimanual compression, one hand is inside her, one hand is on the outside, and we're trying to compress the uterus and massage it to get it to contract. And then the next line of defense is we can dilate and curettage her. Meaning what? We're going to scrape out maybe there's retained placenta. That's making it hemorrhage. And then the next line of defense is we can call IR, interdisciplinary radiology, get her in them to her, which we can get her to the OR, get her IR. The IR, interventional radiology, will literally put the dye in, put in her vessels, light up all the arterial arteries and the uterine arteries and lights them up, and they will see it on the radiation, and then we're going to what? Ligate them, tie them up, embolize them, and the last case scenario is to what? A total vaginal hysterectomy or total abdominal hysterectomy. Just basically we're at that level to save her life. Massage, 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 express the clots, maintain blood and fluid support. Can be an OR case, right? Potentially, surgical case. Vital signs, the main thing we learned in Unit 1, we got to what? Make sure the bladder is not distended. The main thing is, oh, that's right, we got to put a fold in, we got a straight catheter, and it will what? It will allow the uterus to involute. A full bladder prevents the uterus to involute. So therefore, remember we said a full bladder can cause what? Postpartum hemorrhage. And do a lot of labs. So let's think about this. In terms of uterine atony, it's important to what? Massage. Let's go to, then this is from the top here. We're also going to treat for DIC and shock and give her blood transfusion, blood components to save her life. If she's in DIC, she needs fresh frozen plasma, which is what has the clotting factors in it. That will not save her life if she does not have any clotting factors, right? We can do all this stuff and still not save her life. If she has DIC, we need to give her blood components. It's the only way to save her. Okay, we'll go to the next thing, next video.